Good morning. I just want to say thank you to the committee for taking the time to come down to Southeast Missouri. So I appreciate it. Can't hear me? Is that better? I'm Kenneth James. I'm the CEO of Twin Rivers Regional Medical Center Hospital here in Kennett. We're a sole provider in Duncan County, employing about 330 employees, 12 of which are employed. Dr. Shansham, we just spoke to you, is employed with us. I think it's important that I share a couple of facts with you. I'm going to take a little different approach with respect to why I think you need to support Medicaid expansion. And I want to share some data with you specific to how it's affecting us here locally in this hospital here at Twin Rivers. Our tax contribution as a hospital is $295,000. Our payroll exceeds $21 million annually. And more importantly, specific to Medicaid expansion, I want to share a couple of numbers regarding our payer mix. We're 38% Medicaid, 40% Medicare. So you understand how critical it is, every dollar that's reduced with respect to from CMS for our reimbursement. With respect to Medicaid expansion, I'm going to contradict the first gentleman that spoke a little bit, because the facts that I know indicate that the first 3 years are fully funded by the federal government, and that the subsequent years the state has a 10% obligation. Whether we like it or not, the Supreme Court determined that Medicaid expansion is constitutional, with the exception of requiring the coverage by states. It is what it is. We can't argue that. That's been decided. With that, however, I think that it's important that we not worry about elections with respect to voting, but understand the consequences of not passing this to local rural hospitals. And I want to share some data with you. Medicaid expansion itself, beginning January 1, our hospital is expected to have a $2.3 million hit. And again, the numbers that I'm sharing with you are net revenue numbers. These aren't gross. So Medicaid expansion alone, the fact that we're going to lose our DSH payment, because again, contrary to what the first gentleman said, the dollars that we pay for taxes are going for Medicaid expansion, whether we accept it as a state or not. So unfortunately, what happens is, if Missouri doesn't pass it, states like Arkansas that have already passed it will get the dollars allocated for Medicaid expansion. That's a fact. It is what it is. So if we don't pass it, our tax dollars continue to get paid into this kitty, and what happens as a result of that? They get allocated to other states that have passed expansion. That is a fact. There's no disputing that. So again, getting back to some hard numbers, Medicaid expansion, DSH payment reduction, we're going to have a $2.3 million hit beginning January 1st. Again, these are net revenue dollars. Last year, the state decided to change our imaging reimbursement from percentage charges to fee schedule. As a result of that, we have a $4.8 million hit last year. Sequestration hit everybody nationwide. Currently, year to date, we're at a $200,000 hit to our bottom line. Medicaid outpatient reductions percent, we've had a 12% hit the last 2 years. For 2012, we've had a 1.9% reduction. 2013, $900,000 reduction, for a combined $2.8 million reduction impact. For RAC audits, hospitals at risk, $1.9 million. So I'm going to add this up real simple. 2012, our impact was $6.7 million. 2013, we're at 1.1 as we sit here today. 2014, I already know January 1st, I'm going to have a $2.3 million hit because of the lack or the reduction in DSH payments to the hospital. Taking away the RAC impact, I'm looking at a $10.1 million hit to my net revenue in a 24-month period. Talk about modifying your budget. So I can't sustain, and I'm not alone, the rural hospitals in Missouri can't continue to sustain these kinds of reductions and remain open. I read some data recently that indicated that these continued reductions at the pace and the rate that they're going, 40 to 50% of the hospitals in rural Missouri will be closed within 24 months. Surely that's not the intent of the committee. Surely that's not the intent of those in Jeff City. I mean, we serve a vital role in healthcare throughout this state. So surely your intent is that 40% of the rural hospitals in Missouri close. But I'm here to tell you that if we continue to experience reductions that we're experiencing, that's exactly what's going to happen. There's no ifs, ands, or buts about it. Those are facts. That's where we are today. So collectively, I would ask you, as a body, what are we to do in rural? What are the rural hospitals to do? How do we remain viable with these continued reductions? I mean, I just don't understand that. I just need to better understand how we're going to remain viable in rural America, not alone specifically rural Missouri, if we continue to have $2, $5, $8, and $10 million hits every 24 months to our bottom line. And another point that I think is important to make, that my understanding of Medicaid expansion is that this is going to provide expanded coverage for those that are working. And it will change the threshold to 138% of the poverty level, bringing it to about $25,000 to $26,000 a year annually, making those folks eligible for coverage. So it does differentiate the current program quite a bit with respect to the first testimony that you heard. It's a different situation with respect to the eligibility. So we're not talking about folks that currently aren't working or people that are currently taking, whether it be SSR or whatever. We're not talking about that pool of people. We're talking about people that are in education. We're talking about people that are working in fast food, people that are making $20,000 a year that currently can't get coverage, but this expansion will allow them to have coverage. And I believe, as an administrator in healthcare, that regardless of who's funding the coverage, if you have access to healthcare, your outcomes are going to be better in life, period. That's my opinion. So with that, I would just say, again, I would ask respectfully, how am I to survive? How are administrators to survive in rural Missouri with these continued cuts? So I implore you to pass Medicaid expansion, not only because it's the right thing to do, but again, we're talking about a lack of service in southeast Missouri and in Ozark, boom, all the other rural areas that are across Missouri, talking about a lack of services with respect to not passing this legislation. So I'll open it up to questions. I didn't want to take up too much time because I think there'll be some questions.
Doctor.
Thank you for your testimony. You spoke about your current payer mix for Medicare and Medicaid. Could you speak just briefly to your uncompensated care costs?
I'm glad you brought that up. I should have mentioned that, because compounding all the $10 million hits that we're going to have in the next 24 months, our uncompensated care for 2012 was $22 million. $22 million uncompensated care. I appreciate that question. I should have mentioned that. Yes, sir.
Representative Guernsey. Steve.
Thank you. I'm from a rural community as well, Northwest Missouri. I'm on the board for our hospital at home. And I'm always curious to hear from other administrators about the Medicaid managed home model and what model, if you've looked at it, how it would best work in a rural community like what you serve down here. I think this shows a lot of promise in that. Hospital at home services a lot of my area. Heartland has been doing it under a managed home type model proactively the last few years. And I think if there is a promise moving towards a reform model, which I don't think necessarily, surely you're advocating for a continued expansion of the same program.
Absolutely not. Absolutely not. There's got to be some changes.
Yes. So I wonder if you might address that, specific to how it could work in a rural community as it applies to your area.
Well, unfortunately, I'm not as well versed on that and with respect to home. So I'll tell you that at a high level, I think that it would be a nice component with respect to what is planned for expansion. But again, at a high level, I don't feel well versed enough to speak specifically to the home portion of that. Okay, sorry.
Is there a particular then reform method that you would advocate specifically?
Absolutely. I think there is a serious abuse with respect to, that's where I would start. And where I agree with the first testimony is that I think that we can come to the table and come to an agreement with respect to disregarding Republican, Democrat, and come to an agreement with respect to how to better serve these communities. And in saying that, I think that, I lost my thought, but I think that that would be the best option. Okay? I know I didn't answer your question specifically, but again, I'm not as well versed on the whole medical portion, so I don't want to speak out of turn on that.
But there's not any other specific reform type measure that you look at or point at from a rural perspective down here that you would say is something that would be workable or a direction that we need to head?
Unfortunately not.
Because I would agree.
Unfortunately not.
I think that this is beyond a Republican-Democrat measure. I'm obviously very conservative.
Mhm.
But this is where both sides, it seems to me like there's more of an advocacy for just expanding the existing system because we need the money versus what is more and more, I believe, a pragmatic solution to a reform proposal that pragmatically, politically, is the only way we're going to be able to get something done. I'm largely in that.
I would agree with that, but we needed to have that conversation prior to Obamacare getting passed. Because right now, as we said, that becomes a moot point because the legislature's been passed and it is what it is with respect to expansion, either accepting it or not accepting it and losing the dollars if you don't accept it. So but going forward, I think I agree with you. A pragmatic approach is absolutely necessary because we can't just accept the fact that, okay, if you don't take the money, you lose it. If you take it, if you pass it, you get the money and move on by expanding it infinitely. I don't agree with that either. I don't agree with that. What I'm saying today is we've got to deal with what's already been passed and what's in the law and take advantage of that now.
I would just say that while, largely that is the case.
Okay.
I would just recommend, or I would encourage you to look at from the perspective that we don't necessarily have to take everything as it's presented to us. I
agree with
the
that.
whole law was predicated on a number of waivers.
It's true.
I think that a Missouri solution could absolutely entail a number of waivers, and the federal government's in the business of granting those. And I think that Missouri is such a diverse state. Just from looking at it from the rural demographics of southeast Missouri, in comparison to the rural demographics of northwest Missouri,
Right.
there's going to have to be a Missouri solution in order for it to work. And this is where we're going to have to take those solutions and incorporate it into a reform measure. And Washington's going to have to accept what we propose to them. We don't necessarily have to take what they're proposing to us. And this is a great opportunity for rural hospitals especially. But just one last point as it relates to what the gentleman was saying earlier. I think this is something that everybody really needs to be cognizant of who's especially involved in healthcare.
Mhm.
The Commerce Department this morning came out with some interesting numbers. And it showed that in 1929, the economy in the United States grew at a faster pace than what it is this year. So there's a real issue when it comes to revenue, and the taxpayers do need to have an adequate proposal that really is a reform proposal. And I think it's almost counterproductive to get into a discussion whenever we are talking with everybody who's involved,
Right.
from the taxpayer all the way through to the provider. And my brother's a provider, so I understand exactly where you're coming from. But we're going to have to take that into consideration, that the economy is a real consideration and a real portion of this discussion that seems to be almost downplayed at a lot of times whenever we look at the real hard-time facts of uncompensated care and
Right.
the problems with real healthcare delivery. So I'll get off.
I agree with you. Thank you.
Thank you.
All right, we've got time for two more questions, Mr. Serrano and then Mr. O'Leary.
Yes, sir.
And I don't know how familiar you would be with this, but many years ago I was in public accounting, audited a number of hospitals. I once sat down with a hospital administrator and asked them, well, how do you set your rates? Everybody looks at the $100 aspirin.
Mhm.
And basically we talked about uncompensated costs
Correct.
and cuts. And he said, well, I will put as much of that as I can on the paying customer. Whatever the market will bear is where I'm going to push that cost off to, because I've got to run a hospital, I've got to have a balanced budget. Is that still true today as it was in the past?
To a degree, it's unfortunate, but it is true. But it's not any different in healthcare than it would be for, say, insurance or anywhere else. Unfortunately, those that are covered have to pay increasingly higher for those that aren't covered, to compensate for the uncompensated care. So there is some truth in that still today.
So in effect, in addition to the tax consequences to the taxpayer, and again, having been in industry for 30 years and having to provide health care for our employees, the constant increase in our health care costs to our employees has also been impacted by the very factors we're talking about today.
Right. But again, going back to our pragmatic approach, we'd have to go back to the vendors and the other people and the suppliers of healthcare. Because as the equipment for surgery and the equipment to do CTs and everything else, whether it be GE or Philips and everyone else, as those prices increase, of course, it just compounds, it just snowballs the issue. So we'd have to go all the way back to, I joke about this, anything for government or healthcare is always inflated. I can buy the exact same thing in a civilian market or civilian world and get it for half the price. But the minute you say it's for a hospital, the price quadruples. So it's a trickle-down effect with respect to whether it's provided by a vendor, supplier, or the service itself. So to answer your question, there is some truth in that still today. Yes, sir.
Yes, sir. Thank you for testifying. I'm from originally around Carter County, and I've sold health insurance all over this part of the country for many years, up till about 15 years ago. My concern is this. Everybody says we can't expand Medicaid till we fix it. It's fatally flawed, but nobody has told me what those fatal flaws are yet. Can you tell me what those are?
I don't know about fatal flaws. I think that there are some abuses with respect to people that are covered. Even as a provider, I may get the benefit of folks in the hospital, but there are some abuses. Now, I'm not saying we need to develop some kind of rack situation with respect to Medicaid, but I'm thinking that if we could mitigate the abuses, and that's easier said than done, then folks would not be up in arms as much when we talk about adding. Because I think the fact that you say Medicaid expansion, it automatically becomes inflammatory, because when you think about the folks on Medicaid now, you already have a formed opinion with respect to that. This expansion is differentiated because it's covering those that are working.
I understand that, and no system for whether healthcare, financial, or whatever is perfect, so
Right.
There's always going to be abuses. I'm not trying to excuse those, so we don't need to deal with it.
Right.
My concern is, from the private insurance side, I remember years ago when we went from fee-for-service to managed care then.
Right.
My experience has been, and maybe as a hospital administrator you can say that, confirm this or not, that a lot of managed care revolves around two things: limiting how much we pay the provider and limiting access to that provider in an effort to ferret out abuse. And then a lot of times, from what I see as private insurance, that's become counterproductive. And if you're already, your payments are already too low under Medicaid, and we want to put in a managed care provider that's going to try to cut those fees even further and limit access anymore, do you see that as a workable model?
It is a workable model, but think about this as well. What if we fixed my Medicaid reimbursement for a 5-year period? What if we did that? So I don't hit these, even though I may budget a 3% cut, I get hit with 6%, and I get hit with 12%. So why not have a fixed reduction or have a fixed reimbursement for a set period of time and leave it alone? Then I can work with that. But I can't budget anticipating a 3% reduction and then get hit with a 12% reduction on top, compounding on top of sequestration and everything else. I just can't do that. So yes, to your question, but I think it's important also to offer the opportunity for us as administrators. Again, what happens when your budget, when you balance your budget, you don't get as much money as you expect, or whatever happens, you just shift and pull. Well, that's easier to do in Jeff City than it is for me to do in a local rural market. Nonetheless, I've got to live with it. All right?
Thank you.
Sorry.
Thank you for
Too
your
much.
testimony. Be sure and fill out a witness form. If there's other things you'd like to share with the committee, we're open to them, and we'll make sure that they get them.
Thank you, Representative.
We thank you for being
Appreciate
here.
your time.
Jack Pennington.
Good morning. I'd like to begin by saying thank you to the committee members for participating and taking time out of your lives to help us as a state to figure out what direction we want to go in terms of this issue. So I represent Pemiscot Memorial Health System, which is one county to the east, and I'm CEO for that health system. Mr. James covered a lot of material that I was also going to cover in regards to our facility, but I think I can summarize a good bit of that at this point after hearing what he had to say, by sort of echoing his comments to say that, you know, he said that a number I remember was about 40% of rural hospitals within the next 24 months, if we continue down the path that we're moving towards in our state, with the cuts that we're seeing in reimbursement and without an alternative to fill that gap in terms of revenue, that we're going to see a lot of facilities close. Now, I can't speak as to whether or not my facility will be one of those in that 24-month time period, but I can say that we're headed in that general direction, because these cuts in revenue for us as a nonprofit organization are really going to erode our ability to provide care to the members of our community. Similar to what he said in terms of a kind of a profile of our provider that we have there in Pemiscot County, we are the largest employer. We have a payroll of around 20 million. In terms of what we see from a payer mix, which are some numbers that he mentioned, we are in the between 35 to 40% Medicare, Medicaid. When it comes to uncompensated care, we see about 25% of our revenue from a net revenue point of view is uncompensated care. And I want to say that I think this committee, if I understand it correctly, has been put together to consider, weigh the options in terms of reform or possibly adopting the expansion model that's already been proposed. And I think it's a very valuable service that you guys are providing. In terms of the business that I represent today, without a doubt, Medicaid expansion is something that we need. It would create a situation where a large percentage of our customers, if you look at it from the numbers I presented there, 25% being uncompensated, a large percentage of those people would then have insurance and therefore be able to pay for the services we provide, which would in turn put money into our system and allow us to put that back into terms of plant upgrades. We have a facility that was built in 1949. So we could do plant upgrades. We could spend money on equipment improvements. So equipment improvements like imaging, which is very important these days in medical care. Other things that we have in the facility that we could do to improve the care that we're able to provide. And I want to go back to what I was talking about there in terms of either expansion or reform. I think contrary to maybe some of the things that have been mentioned today, I don't believe it's a simple decision to say yes or no to expansion. I believe that this is a time that we're going through that could be very transformative in terms of care. It can be decisions made locally, it can be decisions made on state level or even the federal level. And I believe that there is a specific reform that would be very, very beneficial in terms of what we could do in a rural setting. And I think that that is, in general, over a potentially middle or long period of time, that we would be focusing on wellness as opposed to the type of model that we have these days, which is somebody presents themselves and they are ill already, or they have a emergent condition or an acute condition. And if what we're trying to strive for is to be able to provide care to more people at the same or at a lower cost, then I think a lot of the evidence that you guys will be able to find bears out the fact that a wellness or preventive approach is something that really should be incorporated into what we do in terms of providing healthcare coverage, possibly, or in terms of providing healthcare services. So, back to what I began talking about, which is our facility in Pemiscot County. The Medicaid expansion, as has been mentioned this morning, is in fact law on the federal level and has an unbelievable number of nuances and possible directions that things can take based on the variability that is involved with it. But for our state to have said last year that they wanted to have the flow of money go from a federal taxation standpoint of our citizens going out to the federal government and not coming back to provide a transition, because that's the effect of this law taking place or being enacted, is that this transition in terms of how payments are going to be made is already starting to take effect. So we've had sequestration cuts. As Mr. James mentioned, we also were subjected to the DISH, which for us was $1.5 million on a yearly basis. And as I mentioned before, for a nonprofit organization, that's substantial. So for us to not involve ourselves as a state, as a healthcare portion of the state in this program, we're effectively saying that we're taking a path to create more severe challenges to provide health care to especially rural, but citizens of our state everywhere. And I would suggest that we would look hard at the possibility of seeing what form we're willing to take as a state of involving in this program, which is the direction that healthcare is going, and at the same time being involved in the process of changing it so that we don't miss out in the short term on being able to continue to provide very high quality health care to the citizens of our state in all of the ways that that affects our populace in a positive way. People are at work more, you got more productivity, it helps the economy, helps quality of life. And at the same time, having a thread going with that, which is concerned members and involved members of our state working to change this particular legislation as it affects healthcare and put it into the form that we want it to represent us as a state of Missouri. So with that, I'm going to take questions if you guys have some.
Dr. Pooh.
Thank you for coming, and I sort of appreciate, the conversations that the hospital had about, the economic impact on facilities, particularly in rural areas. And I understand that, and I think most everybody here understands that, but I think I would like for you all to perhaps take a bigger picture of it. Now, how does this economically affect your communities? We know that in the vast majority of rural communities, the hospitals are either the number one employer or the main employer. And I'm not trying for you to say, well, yeah, I had to lay off this, not necessarily specific numbers or anything like that, but I would like for you to discuss perhaps the economic impact on your community, whether it's overall jobs, or whether it's if you have to cut service lines, what's the trickle-down effect of other services that are for other businesses within your communities? Can you kind of frame a picture of how that looks?
Sure. So as I mentioned, our facility is the number one employer in our county, and it is very rural county, farming land, is a vast majority of the acreage within the county. And there's a historical perspective I can provide that I think will illustrate what would be expected, in the event of a large negative change to our particular organization. Between, I guess, maybe the 60s or the 70s, in terms of decades, and 20, 30 year, in one generation's period of time, mechanization of farming occurred. So you had a county with about 50 to 55,000 residents, and there was a family on nearly every 40 acres. They were farming that 40 acres, and they had their house there. And as farming became mechanized, the population dropped precipitously. Now we have around 18 to 19,000 people in the county. And the reason for that was those jobs that were provided by that industry went away as the machines were able to farm more land. So you saw a reduction from 50 to 20,000 roundabout in terms of population. If something happened that created a situation that we had to sizably reduce the health care services we could provide in the county, or potentially the entire organization goes away, then you're talking about seeing the same thing happen in a condensed window of time, potentially 2 to 5 years. You're going to have that population again decrease by over, let's say, if we've got 20,000 now, I mean, it could go down to 8,000 or 9,000, because you're going to reduce that number one employer, so those jobs and families are going to leave, but you're also going to take the health care away that's provided within the county, so you're going to have other families that are able to move to a different location to get them closer to the schools and the health care that would be provided in that situation. Now, I know you may have been wanting to have me answer more in terms of monetary figures, but I think that provides a pretty good overall look at what we would anticipate happening in those type of events, or in the direction that we're heading, I guess is one way to say it.
Okay, Mr. Long, and then Ms. Haycraft after that.
I apologize because you said these, but the acoustics are pretty tough. Can you, the name of your hospital in Pemscott County?
That's right, Pemscott Memorial Health System is the overall name.
And your dish payment reduction is 1.5 million. Your uncompensated care is?
The figure that I provided was about 25% of net revenue.
Okay.
So if you wanted to attach that to a harder number, that'd be between 8 and 9 million.
Okay, and is there further reduced payments that you're expecting in your budgeting process for the reduction of Medicare and also sequestration?
Absolutely, yes.
And do you have a general idea
Number
what that
for the
is?
impact there?
The financial impact?
Yes, I'd say between 3 and 4 million.
Okay, thank you. Thank you, Mr. Chairman.
Thank you, Representative Hampton, and thank you, Mr. Pennington. Your testimony is very compelling. I have a great love for rural hospitals and critical access hospitals, and I'm very sensitive to what you're saying. I don't want to see them closed. But I am curious about what you perceive to be the cost of both federal and state regulations to your hospital in terms of number of employees and time, money that it takes to comply. And would some form of deregulation in the healthcare industry be helpful to your hospital?
That's a good question. I believe in one hand that deregulation could absolutely benefit us in that it would allow more of our personnel to be dedicated to the primary mission of healthcare, of providing care for people in our community, as opposed to spending their time on reporting what we've been doing or understanding what the new regulation is and how that needs to be woven into our day-to-day routines in order to tell some organization that we're doing things the way that they expect us to be doing them. However, I believe that's a tricky path to take, because if you don't deregulate in the proper fashion, then you might end up with problems. You know, you should probably expect to end up with problems in terms of quality of care and outcomes maybe going down, because unfortunately some people don't always do things the right way unless they're very regimented and required in the way that they're made to do those things.
Just follow-up question. What percentage of your FTEs is involved in direct patient care at this time, and what percent is involved in supervisory, management, and administration?
Our organization is probably not highly representative of the healthcare field as a whole, because over a period of time we've already had to, what I call, flatten the hierarchy. We've taken out a lot of the administrative positions to be able to stay viable. So at this time, I would estimate that we're probably 80% directly patient care and only 20% administration, which, as you can imagine, results in a little bit of hair pulling sometimes from the administrative folks.
Okay, I believe, Mr. O'Leary, you had your hand up.
Yeah, just a quick question. You said that if the Medicaid expanded and those extra dollars come in, might be a chance to upgrade the hospital and stuff. One of my concerns as an advocate for mental health issues in the state is we've lost so many beds dedicated to mental health issues. Right now we have one bed for every 1,700 residents. I have a map on my desk I forgot to bring, showing people from all over the state of Missouri that go as far as Nevada to get into a hospital bed for psychiatric care. You're not involved in that now, I don't believe. Do you think any of the hospitals in the local area could get back into providing mental health services if we had funding to cover those folks with mental health issues?
I would say that's a certainty, and actually we do have a 52-bed inpatient psychiatric unit with adolescent, geriatric, and adult areas to be able to care for those individuals. So that's something that we very much feel is a need for the state of Missouri's population as well as our local area. And you know, in addition to that, I would say that that service is one that can support itself in terms of the way the structure is set up for payment versus treatment. So, you know, that may be something that some of the local providers decide to kind of venture into, whether or not the reimbursement comes from this expansion, but absolutely in that case.
Yeah, thank you. I misspoke. I meant it's the hospital in Kennett, I think, that doesn't have any psychiatric services, but it's true. But I think the number of one person, one bed for every 1,700 is probably pretty accurate, don't you think?
I believe you're correct. I think that's probably something that may have been around a year or two and probably factored into the decision of our facility, seeing that need. I think the state at one point had a sponsored or controlled large facility, and that may have closed for some reason, and they decided to, you know, let the private sector maybe handle it more, and I think that's probably when we got into that business because we saw the need for it in our community.
Thank you very much.
Thank you for your testimony. Be sure and fill out a witness form.